In this module, we will be discussing neurodynamics of the lower quarter. I would like to give a special thanks to Renee Ostertag for some of the content within the slides. Our objectives today will be to present to you the following information so that we may have a more active discussion in lab. After this module, you should be able to define neurodynamics, list key concepts, discuss principles of assessment and treatment relating to who, when, why, and how, as well as cite evidence for the use of neurodynamic treatments in common conditions. This table can be found in your course packet as well as on Canvas. Please fill it out as you listen to this module and come prepared to discuss in lab and use as a reference as you practice. Neurodynamics is based on the hypothesis that your nerves require full movement for pain-free function, and that movement both creates and requires space and blood. Movement, space, and blood maintains and helps restore homeostasis in and around the nervous system. This practice used to be termed neurotension, and you may hear some clinicians still use this phrase. However, the term has transitioned to neurodynamics. This is because we are looking at more than just length, which is merely only one mechanical property of a nerve. What we are actually assessing and treating is both the multiple dimensions of mechanics and nerve physiology. Examples of mechanical properties we are assessing is the nerve's ability to bend, compress, turn, slide, glide, and elongate. If a nerve is dysfunctional, it could experience difficulty or pain with any combination of these properties. Examples of physiologic changes that may create a dysfunction in neurodynamics or be a response to dysfunctional neurodynamics is intraneural edema and changes in thermal and mechanical hyperalgesia. This means what used to be considered a, quote, normal touch or temperature is now considered dangerous or painful to the nerve. Treatments addressing neurodynamics have proven to decrease edema, increase fluid dispersion, decrease hyperalgesia, and reverse the increase in immune response, as well as improve the nerve's ability to tolerate bending, compressing, gliding, and elongating. An unhealthy nerve may result from mechanical or physiological impairments. Mechanical impairments affect the ability to compress and distract. These are due to both intraneural and extraneural factors. Intraneural factors include adhesions or fibrosis within the nerve sheath or dura. Extraneural factors include fibrosis or adhesions between the dura and surrounding connective tissue. Physiological impairments affect the chemical and electrical abilities of the nerve. These impairments are due to poor blood flow, dysfunctional ion channel activity, and inflammation. The following few slides are explaining key concepts to understand when using neurodynamics as assessment and treatment. First is the concept of the container. A nerve must pass through dura, and dura must move through and around tissues, including muscles and bones. The musculoskeletal system exerts stress and movement in neural tissues, which can create changes in the way a nerve moves and functions. Injury or impairments to the container can affect nerves. For example, swelling due to a sprain or strain can irritate a surrounding nerve, and a muscle in spasm can compress a nerve. The reverse is also true. Sensitive nerves may sensitize surrounding soft tissues via trigger points, decrease muscle spindle threshold, and protective muscle spasm. This could lead to a vicious cycle. Another important concept is that the nervous system is a continuum, both mechanically, electrically, and chemically. This is where the concept of double crush comes from. An individual can report a history of back pain and then present with plantar foot pain. The irritation to the nerve occurring in one place can lower the threshold for irritation in other locations. This concept of a continuum also helps us differentially diagnose as well as use remote mobilizations in those that are irritable. For example, if we are questioning if posterior thigh pain is hamstring or sciatic, we can ask the patient to change their head position and assess for a change in symptoms. If they have a change in symptoms with a change in head position, we can conclude the symptoms have a neurodynamic component. Another key concept is that order matters. That which moves first moves most. So when we start with dorsiflexion of the ankle, we will see more movement on the distal end of the nerve versus the proximal end. The reverse is true if we move the hip first. This will become more clear and of importance when we speak to treatment based on irritability of the nerve or joint region. T4 through 9 is considered the critical zone of the nervous system. This comes from the fact that here the central foramen is the most narrow, meaning there is less room for error of compression and dysfunction. This is also where we see most tension occurring during a slumped or bent posture. The autonomic nervous system also resides here. To summarize so far, nerves need movement, space, and blood to be happy and healthy. Nerves can become unhealthy via mechanical or chemical disruption. This disruption leads to venous congestion, which can then lead to decreased intraneural circulation, and then to hypoxia, which results in an inflammatory response, more edema, and then finally fibrosis or the inability to attenuate or tolerate loads. The following 2 slides are reference slides for filling out your chart and participating in lab. Please come prepared to discuss this anatomy in lab. We will now begin to discuss neurodynamic testing using the concepts we just presented. Why do we perform neurodynamic testing? It is a way to differentially diagnose the pain source as well as assess for related impairments to the patient's activity limitations. We are looking if nerves can move and if they like to move. Every movement and posture tests our tissue's abilities to conform to demands, including compression and distraction. When muscles contract, nerves are compressed. When we move, nerves bend around joints. If nerves are unhealthy or irritable, symptoms may occur, so we need to screen for this. So when should we look at neurodynamics? Does every patient need a thorough assessment of the system? My advice to you is that these subjective flags should get your attention. These flags include pain in the path of a nerve or pain that changes often. Some patients say their pain has a mind of its own. Pain during ischemic conditions, including night pain or pain with static postures, or pain with cold temperatures, may also indicate the need for assessment. Sensory changes should also grab your attention, especially if they contain any of these specific descriptions. Be on alert with motor changes as well, including fatigue, but please remember that patients may not always have motor or sensory changes. If patients have sustained injuries around a nerve, we should remain suspicious. For example, with a history of an ankle sprain, we may want to assess the dynamics of the peroneal nerve. A few anecdotal pieces include if a patient feels like they keep stretching and never seem to loosen, or if stretching makes their symptoms worse. Also, it may be a good idea to screen for this system if patients have been immobilized for a period of time. Once past the subjective piece, here is a list of common musculoskeletal conditions that at times may have a neurodynamic component to their symptoms, thus testing is warranted. Also, to help your decision making, from a chronological and tissue irritability standpoint, it may be of importance to assess neurodynamics in more subacute and chronic phases, or even later in a plan of care if we are not able to see improvement with routine interventions, or if we are unable to reproduce the patient's symptoms consistently with a thorough musculoskeletal screen. Possibly of more importance is who to not perform these tests on. This list includes those who present with red flags, demyelinating conditions, tumors or inflammatory diseases, diabetes, though a pilot study was done recently in this population, so stay tuned for an update here, progressive radicular signs, and highly irritable and acute signs. You may proceed slowly and with caution when testing those you are suspecting have an irritable nerve root pathology. However, treatment will not typically start here. We also want to take extra care and move slowly and methodically in those with acute or irritable states of disc pathology or compartment syndrome. This is especially noted with elongating and pinching maneuvers. So now that you know why we test, when we test, and whom we should perform these tests on, let's discuss how it works. We will practice this hands-on in lab, but please be familiar with these principles. Always standardize the position. This means no pillow. Be mindful and purposeful with your language. Tell them what to expect and what information you are looking for, but avoid the use of the word nerve. Move slowly into positions and add movements gradually. Feel for tissue resistance versus relying on the patient's report. Use your knowledge of the continuum concept and of anatomy to create sensitizing maneuvers. Use sensitizing maneuvers that are remote from the location of the symptoms. If a person is coming in with ankle pain, we do not want to use dorsiflexion as a sensitizing maneuver. We want to use something remote, such as the head, because we will not be able to conclude what tissue is at fault. Here is a reference chart for nerves tested with a straight leg raise. You may use this information to fill out your chart for lab. Of special note is using the straight leg raise when assessing for nerve root pathology versus peripheral nerve pathology. The straight leg raise test will be performed as a passive test without the use of ankle dorsiflexion. When we are suspecting a peripheral nerve problem, meaning any pathology distal to the nerve root, we will use sensitizing maneuvers. This is another reference slide showing and describing the slump test. Please note that this is not to be used in acute patients, especially when disc herniations are suspected. Moving to the anterior side of the leg, the prone knee bend assesses the dynamics of the femoral nerve. The problem in this position is we cannot use the spine to sensitize, thus moving into a sideline position is optimal. In this sideline position, we can also look more closely at the obturator, saphenous, and lateral femoral cutaneous nerve. Here is another reference slide to complete your chart. So what is considered a positive test? You will find that many of you have some symptoms or impairments with these tests. To be considered positive and an impairment in which to intervene upon, we must observe the following results: a reproduction of the patient's symptoms or a change with sensitizing maneuvers, a difference in range of motion of 10 degrees or more, and in the prone knee bend, symptoms at 80 to 100 degrees. Here is another breakdown of how to interpret the test. A point I want to make here is the difference between the interpretation of a positive test in regards to a nerve root disorder versus a peripheral nerve disorder. In the case of nerve root pathology, the straight leg raise will either reproduce the patient's low back or low back and lower extremity symptoms between the ranges of 30 to 60. In the case of a peripheral nerve root, a positive test is a reproduction of the patient's lower extremity symptoms or a difference of 10 or more degrees. We must be extra careful to be specific with the sensitizing maneuvers here to distinguish which peripheral nerve. This may go without saying at this point, but we intervene to restore the mechanics and normalize the physiology of the nerve. Specific to the mechanics, NDT sets to facilitate movement between neural structures and their interface or container. Specific to the physiology, we set to improve circulation, ion flow, viscoelasticity, all to decrease sensitivity to mechanical changes. NDT sets to improve neuropathic pain, resolve related impairments, and improve fear of movement. NDT interventions use mechanics to treat pain or impairments of neural and non-neural structures. What exactly is an NDT intervention? It is a mechanically based method of treatment addressing both neural and non-neural structures. It includes patient education, patient positioning for decompression of nerves, passive or active neural mobilization techniques, soft tissue techniques, and exercise. This method allows for a holistic treatment of dysfunction. When do we typically see NDT used successfully in a plan of care? During acute or irritable states, mostly patient education and purposeful positioning will be used, especially in the presence of a nerve root pathology. When symptoms have progressed to the subacute or chronic phase, or when symptoms are stable, more neuromobilizations will be prescribed. We may also introduce these techniques if we do not see a change in symptoms after 2 to 3 sessions of standard care. We reserve these techniques for those who have demonstrated a positive test, meaning that the assessment leads to reproduction of their symptoms, or they have a difference in more than 10 degrees, which you reason as being a related impairment. Some specific examples in the lower quarter include a stable lumbar radiculopathy, which has been centralized for 2 weeks, hamstring strains, piriformis syndrome, or plantar foot pain. We will discuss this more in lab, but I wanted to expose you to some guiding principles. When initiating treatment, start with undertreating. Start distal to the area in question with non-provoking techniques. In most instances, we treat the container, then add neuromobilization techniques, called a slider. We dose these treatments similarly to joint mobilizations. When considering where to start and how to progress a patient, begin with the question of irritable versus non-irritable. If a symptom or condition is irritable, the goal is pain relief. We will use postures to relieve tension or compression on the nerves, as well as non-provoking sliders. You can almost think of it as grade 1 or 2 mobilization. In non-irritable conditions, our goal is to improve the symmetry of the test to the other side, with minimally provoking sliders progressing into tensioners. Some patients may never get to tensioners, and we will discuss this more in lab. Treatments may be progressed by changing the reps and times, amplitudes and grades, and order of movement. A quick note on a slider versus a tensioner, which we will demonstrate in lab. Slider is where we are adding tension on one end while removing it from the other. A tensioner is where we're adding tension to both ends at the same time, both proximally and distally. The use of sliders are encouraged as research indicates more total excursion and less strain of the nerve during that condition versus a tensioner. Also, tensioners may create more irritability to the nerve, especially in suspected conduction impairments. The following are some reference pictures of treatments we will be practicing in lab. We will work on the container, as well as sliders with soft tissue mobilization, and also sliders with joint mobilization. And finally, do all these concepts and principles result in improved patient outcomes? A recent systematic review indicated that using neurodynamic interventions in the form of a straight leg raise was effective in plantar heel pain and tarsal tunnel syndrome, while the use of the slump assessment and treatment was effective in nerve-related low back pain. In other regions, the evidence is insufficient and recommendations were unable to be made due to the lack of consistency of terminology and including the use of sliders and tensioners interchangeably. This concludes the module. Looking forward to seeing you in lab.